This afternoon, for just the next few minutes, I want to talk to you a little bit about health, about healthcare, and in particular about healthcare here in Hardin County. And then I'll talk a little bit about our federally funded mobile clinic that we have here in the county. But as a backdrop to that, let me first set it up with just tell you a little bit about Hardin County. I'm sure you're aware of the county, but let me just give you some data. It's about 32,000 people that live here in Hardin County. 1 in 5 live below the poverty line. About 13% of our population don't have health care insurance. And as you look at who those folks are, it tends to be people under 30 and people who make less than $25,000. We're in a federally designated health professions shortage area, and many parts of our county are federally designated as medically underserved areas. So there's not enough providers to provide the medical care. Now, 80% of adults reported last year that they had to go outside Hardin County in order to receive health care services. And more than 40% of adults report that they don't have a physician or any other health care provider that they routinely see for care. So you can see that there's some significant concerns that are associated with the county. If you look at some of the reasons why people don't have physicians, there's a number of them, but they include they can't afford to go see a physician, and they don't have health care insurance, so there's no coverage for that. Some report they just can't find a physician that will take them because we have a limited number of physicians here that we close practices. And some report that practices are ended or gone to part-time or they no longer see patients. So there continue to be a number of challenges and issues associated with those aspects here. So we've got social and economic and geographic issues that play into health care. So let's talk a little bit about health in the county. 1 out of every 3 adults has high blood pressure, 20%. 1 out of every 3 adults has high cholesterol, 20%. We have a significant percentage of patients, 35% of patients who are obese, and another 35% who are overweight. So if we look at obesity and overweight, there's 70% of adults in Hardin County that demographic. 1 in 5 adults smoke. So when we start looking at things like high blood pressure, high cholesterol, smoking, and obesity, those are the key pieces that play into chronic disease. And we see a lot of chronic disease in the county. 13% of adults have diabetes. 16% of adults have asthma. About 32%, so 1 in 3 adults has arthritis, probably carrying a lot of that extra weight. 12% of adults in the county report that at some time in their life they've had cancer. So we have a number of different issues that play into sort of long-term chronic disease problems. 1 in 4 patients in the county have reported that over the last year they had some type of a medical problem or were limited in some way to a physical or mental or emotional concern. If we look at some of the preventive activities that could be occurring in the county, I think we've got a little ways to go. More than 55% of adults over 65 years of age report they haven't gotten a pneumonia shot. Again, they all should get a pneumonia shot. 55% of adults last year didn't get a flu shot, and they all should get a flu shot. So we've got issues and challenges and problems that come from our social, economic, and geographic concerns. But I think we've got some unique health issues here in Hardin County that we, just the College of Pharmacy, we think that we can focus on and help improve. Now, I want to sort of turn the dial a little bit here. I mentioned that we're in a health professions shortage area. And you probably have read or seen someplace in the news that by 2020 it's projected we will have a shortage of primary care physicians, somewhere between 20 and 30,000 across the country. And as I look at that, I think that number is drastically low. I think it's much smaller than what the real need is. Because in America today, we don't have a health care system. We have a sick care system. Think of this current model. People go to see the doctor when they're sick. Not only is it a cultural thing for us, it's the way we built our economic model to pay for health care. And so people have to have an illness in order to go see the doctor. Now, if you think about the U.S. healthcare system, it's kind of a piecemeal approach to providing care for the sick. And it's really focused on procedures and tests as opposed to preventative activities. So let me give you an example. Most of you probably won't go to the doctor until you're sick. And then when you go to the doctor, he or she will ask you to get some tests done. So they might order X-ray, or a CT scan, or an MRI. They might say, go get some blood work draws, do lab work. Now, if you think about it, you pay the doctor when you go see the doctor, then you go get this testing done, and you pay for the testing. And then oftentimes you have to pay another doctor to analyze that testing and tell you what it all means. So when you get a radiologist to read your X-ray reports or your CT scans, you pay for that. Then you got to go back to the doctor you saw in the first place and find out what all those tests mean, what's wrong with you, what your treatment should be, and you pay for that again. That's the classic approach to healthcare in America. It's kind of a piecemeal approach that's focused on what is reimbursable, and that's the type of thing we migrate to. So we're much more focused on surgery than things like cognitive services, like behavior-changing counseling. We're more focused on specialty care than we are on primary care. And that's the nature of our system. And so, I think it brings to mind to me some of the issues I've talked about here. Most chronic disease starts innocently with some modifiable bad habits, right? But we don't have a focus in our country on modifying those bad habits until they become disease. There's no treatment for subclinical disease. You have to have symptoms, you have to have something wrong with you in order to go on to get treatment. And so what happens is we have people who, let's take, for example, the two most common risk factors for death in the country, obesity and smoking. So folks who start with those habits in their early adulthood are going to live till probably their mid to late 30s before they really begin to have symptoms associated with those diseases. Then they go to the doctor. Then the doctor prescribes treatment. And they begin a lifelong course of treatment for a chronic disease that was caused by these modifiable preventable problems. I think one of the challenges that we have is that preventative strategies are cost effective, but they're not widely adopted because you can't patent them, and honestly, you can't make money on them. They're just not profitable. Look at where we spend money on healthcare research in this country, through the NIH. Most of the funds are focused on new therapies to treat diseases as opposed to preventative approaches that could potentially really reduce the burden of chronic disease across the country. So I think there's sort of a mismatch in economic incentives. Our focus on treatment has really obscured or interfered with our ability to really provide any substantial focus on prevention. As I say, in America, we're focused on sick care as opposed to health care. And that is in part how we put together our grant back in the fall of 2014. We wrote a grant to the Health Services and Resources Administration, which is a federal agency within the Department of Health and Human Services, focused on providing care to the community in the form of a mobile clinic. There was a 2013 Community Needs Health Assessment done here in Hardin County. The top 5 health needs, health priorities for the county are preventative health education, to teach people how to avoid obesity, how to avoid or to discontinue using tobacco products, things along that line, preventative services. Number 2 is manage medication burden and help patients to use medications well when they have chronic disease. Number 3, coordinate care. So when people have needs, help to plug them into the places within the county where they can get services. Number 4, provide prevention interventions such as immunizations, health risk assessment, and other types of things that are preventative in nature. And number 5 was prevent falls in the elderly. Falls lead to fractures lead to morbidity and mortality. Those are the top 5 identified with this needs assessment. county. We did our own needs assessment in the college and found a couple of additional things that kind of play around those issues. One of which is we don't have enough healthcare providers in the county. There's a limited number of physicians in the county, all primary care providers. So that was one. And the second one was the access issue for patients to interact with the healthcare system. It's not all just providers. We live in a big county. Hardin County is large. And the healthcare services are really focused in Kenton and a few over here in Ada. And so transportation to those places where there are healthcare services was a real issue for folks. So it was with those things in mind that we began to put together this grant that we wrote to person. The goals of our clinic are fourfold. The first is to improve access to care. The second is improve health knowledge. The third one is improve outcomes, health outcomes for patients here in the county. And the fourth is whenever we can, we try and plug people into medical homes to connect them up with systems that will help them sustain them. Now, to be successful, we needed to reach out in partnership, and so we formed a consortium with a number of healthcare providers here in the county. So ONU is the lead agency in that consortium, but we partnered with the Kenton Hardin Health Department, with our critical access hospital, Hardin Memorial, over in Kenton, and then with the federally qualified health center that's here in the county, the Kenton Community Health Center. Those four groups came together to really provide the wraparound services and the referral network to make it successful. So the program is pretty straightforward. We designed an interdisciplinary clinic made up of student healthcare providers under the supervision of licensed healthcare professionals to go out into the county and provide health, education, and healthcare services. So the idea was to overcome the health profession shortage by providing our student trainees. We've roughly about 42% of all the students here around Northern are in healthcare professions training programs. So we have a large number of students who are prepared to offer those types of services that we require. And our clinic is mobile. So we go to where the patients are. We will go 2 to 3 to 4 times a week out into the community. We see patients here in Ada and in Kenton, but we go to Mount Victory, or we go to Alger, or we go to Forest or Dunkirk. Go where the patients are so that we can meet them where they are to provide those needs. Oftentimes we will go to community events. The Hardin County Fair is a good example. Just recently we were there each day to try and provide these types of services. I say we, and I use we in sort of a capital we, but it's not me. We've hired a clinic director, Amy Fainus, and Amy and her team of students and residents goes out, they jump in the car and go out and see patients. The mobile component of this allows us, although we don't have a big Winnebago, with a polar bear wrap on it, which would be nice, but we didn't have the funds for that. So what we do instead is Amy takes her team out and they go to churches or schools or community centers or other public buildings in the area, and they set up shop. And they come on a routine basis so people know that they're coming, and they provide their services. So at every clinic, the types of services that we provide routinely are preventative health education. So, we talk to patients about nutrition and exercise. We talk about tobacco avoidance or tobacco cessation. We provide disease prevention tips. We go through a healthy risk assessment. So preventative health, the health component of health care. For those patients who are taking medications, we help to figure out how they're taking them, what they're taking, what they need to take, what they don't. We help them to coordinate how they use them. And these are for some of those chronic diseases that we see, like high blood pressure, cholesterol, diabetes, asthma, COPD, behavioral health disorders, those types of things that require intensive medication care. We provide immunizations for adults and for children. We do health risk assessment and health screenings. We screen for things like body mass index. We screen blood pressure, blood glucose, blood cholesterol, hemoglobin A1C. We will help assess risks for cancers like skin cancer, or risk for breast or cervical or colorectal cancers. And then lastly, we will try and make referral for patients whenever it's necessary or whenever we can. So we plug them into existing healthcare systems that are here in the county. So as I said, we've been out, literally hundreds of clinics. We've seen hundreds of patients. We have a small practice now with probably about 125 to 130 patients that come back and see us on a routine basis and we try to provide follow-up care. So it's kind of exactly what we had hoped originally to set out. So let me just share with you a couple of stories so you can kind of get the flavor for what's happening at these clinics. And Amy has shared these with me. She told me about a gentleman that had come into the clinic and had gone through the screening process. And this gentleman had a blood sugar of 300, a fasting blood sugar of 300. That's high. Normal fasting blood sugar should be 75 to 90. So the team sat down with him and began to talk to him, and as it turns out, he knew he had diabetes. But he didn't have a physician, he didn't follow up with anyone, he didn't manage it because he didn't know what diabetes was. He really had no understanding of the disease, the complications that come from the disease, or how he could possibly manage it on his own. So the team sat down and talked to him. They spent some time to educate him about what glucose is, why it's there, why your body needs sugar, why it has high amounts of sugar in diabetes, what some of the complications are that come from that, how he could potentially manage that on his own or in conjunction with a physician. So they provided him a lot of education. And in doing that, they talked about some of the complications that come from diabetes. Damage to the eyes, damage to the hearing, damage to the kidneys, damage to the nerves. And he said, I had blurry vision now for several months. I had no idea that it could have been associated with diabetes. So they educated him. They called and got him an appointment at the FQHC in Kenton. He went to see a physician there. He got on medication therapy. They saw him back several weeks later with a normal blood glucose and taking his medications to help manage his disease. So that's a perfect example in my mind of health care. Identifying problems and helping the patient understand prevention. So that whole preventative aspect of what he can do in order to prevent further problems. To provide care so his health got better. His blood glucose came under control and hopefully his health will continue to improve. Plugging him into a system here in the county that's there and can provide care for him, but he had no knowledge that it was there. So he was a great example, I think, of kind of what we're trying to do with the clinic. The other example that Amy wanted me to share with you is a lady who came into the clinic and her blood pressure was high. And so the team, in discussing with her, found that she had been prescribed 10 different medications. And she didn't understand any one of them. And she didn't necessarily take them or take them in any particular order or time because she really didn't understand why she was using them or what they were for or what she was supposed to get out of them. So they went through a process of what we call reconciling those medicines to determine which ones she needed to be on and talk with her about how to take them appropriately, the time during the day to take them, what to expect when she takes them. And then they worked with her to create a schedule for her to follow so that she could take the medicines that she needed to take for a while. So again, when they saw her back in about 3 weeks, her blood pressure was back to normal. She reported taking her blood pressure medication now and was feeling better because she knew how to take her meds. Again, just I think a good example of it isn't brain surgery, and I think one of the things that we think of in providing primary health care is that it has to be physician-driven. But the reality is we've got this shortage of primary care physicians. And if we look in Hardin County, the things that we need, the 5 to 7 top priorities, are not things that require a physician, at least not a primary physician. Someone in referral, yes. But a lot of the things we can do as healthcare professionals to help people understand health and improve their health. So as I conclude here, I want you to come away with at least this idea that healthcare in America is really misnamed. We live in a society of sick care. And Hardin County is really a microcosm of that bigger problem that occurs across the nation. We have focused on ways to refocus efforts on healthcare, preventative healthcare, so that hopefully not this year, probably not next year, maybe not in the third year, but if we look over the course of a 5 to 10 year period of time with this type of a focus on teaching patients in the community how to prevent disease, we can change the health of the county. And we can change and improve the health of the people that live here. So that hopefully Ohio, in 10 years, will look to Hardin County as a model for not only the way to provide preventative health care services, but also as leading the state in terms of some of those health-related issues I mentioned to you. So thanks for listening to me. I'd be happy to take your comments or your questions if you've got time. Yes, ma'am?
Where did the data for the statistics come from? You mentioned a report.
Yeah, so a lot of the numbers that I gave you came from U.S. Census Bureau data as well as from a recent community health needs assessment that was conducted. When we originally put together our grant back in 2014, we looked to a 2013 health needs assessment, which was updated in the last couple of years. So every couple of years, Hardin Memorial Hospital, in conjunction with the Hospital Council of Northwest Ohio, which is based out of Toledo, bring together interested community members and conduct a health needs assessment. And then we publish that. Anything else? Well, thanks for listening to me. Now the really cool topic is going to come up. Thanks very much.